and other agencies, just pulling together to just like be stronger. So really grateful to be part of it.
Well, Joy, thank you for building our foundation. And we'll think about you a lot as we gather to learn and share information as we go forward. And we wish you absolutely the best.
Thank you. And this was a very, as I said in my email, this says more about David than it does me, because he's the kind of person that just lifts everybody up, that supports them, that makes them feel honored and listened to. So we are very lucky to have you. So thank you.
Thank you, Joy. All right. So I want to raise to people's attention that Beth has put into the chat a sign-in form. You'll help us a lot in keeping track of our impact as an organization. If you'll click on that link and do a sign-in, that'll be a great help. Now we're going to hear a presentation by Mimi Dahl, who is Director of Research at DuPage Federation. She's going to be sharing what she's learned over the last few months. Mimi is a clinical community psychologist, and she's an evaluation research specialist. She has been senior program evaluator in the Chicago Public Schools before she started her own consulting company, Candeo Consulting, where she provided full range of services to health, education, and human services sectors, including needs assessment, program development, program evaluation, data collection, and strategic planning. I'm very pleased that last December, Mimi joined our staff, where she is now Director of Research, and I invite her to the microphone to share what she's learned.
Hi, everybody. Can everybody see my screen okay before I get started? Okay, awesome. Yeah. Thank you so much. Thank you. Appreciate it. We are going to be talking today about how health and human service providers have been using data in the work that you all do, where we see gaps both in data sources and capacity to use data, and where we can address some of those needs. As Dave has alluded to, I started my role at the Federation about 10 months ago. And one of the tasks that I began with was meeting with a lot of the people in this room to say, how are you using data? Where are you seeing gaps? How can we strengthen those systems? And it was such a gift to get to know all of you and the work that you're doing better. And I really hope that today you see that work reflected here in this presentation. Okay, let's go ahead and get started here. Okay, so what we did was an exploratory study about how health and human service providers are using data. Where are we seeing gaps, both in data sources and in our capacity to use data? Do we not have the appropriate training, just enough bodies in the room to get the work done? And then also what's working well. We want to learn from what's working well and amplify and share that out. We conducted 18 qualitative interviews with 22 key stakeholders. It was a lot of good data. I think we had about 500 pages to comb through. So thank you, everybody, for your input and insights. We appreciate your time and effort on this. And I wanted to share with you a little bit about who we talked with. We saw about 9 different community sectors represented here, a little bit heavier on the health and government sectors, which probably shouldn't be too terribly surprising when we think about health and human services. But this is who we met with today over the course of the past several months. And when we asked, how are people using data in their organizations? One of the first things people shared with us is that they wanted to be able to describe the population that they are serving and understand how best to help that population. So who's using our services? Where is there the greatest need? Are we reaching all the people that we need to? Can we break it out? Are there different experiences by race or ethnicity, by gender, by age, by location? All questions on the table that people wanted to know the answers to. Also, can we improve our service delivery? Are there barriers that we can uncover through data collection that we can address and make our services better or more applicable to people? Are we achieving the outcomes we want to? How strong are our outcomes? Does everybody enjoy the outcomes that we want them to see, or maybe some groups more than others? All of those, again, important questions for us to be able to ask and answer. And then also people wanted to use data to plan forward. So can we look at trends over time and use that information to forecast into the future what we might need to be doing, how much service we might need to be providing, how many staff we need, things like that. And then we also want to be able to use data to communicate with our stakeholders. So who are the professional peers that we need to share this information with? Who are the funders that we need to report back to and share what we're doing and what's working and where we can adapt? And then also to our community members. We know that ultimately those are the people that we're accountable to, and we want to make sure that our community is also aware of the work that we're doing and outcomes we're achieving. Okay, one of the first gaps we are going to talk about is when there is insufficient data, when there is just not as much data there as people would like to see. And this happened in a couple ways. One, when people felt that data wasn't disaggregated to a level that they wanted it to be, so not broken down in a way that's helpful to the work that people are doing, or what I would consider more surveillance, like there just aren't the rates or counts of things that people want to see. This was particularly felt in the mental health field. People noted multiple times, we just can't find the youth mental health data that we want to see, particularly at local levels, that we are really challenged by that. And I always like to bring this back to why does this matter? The kind of the so what question, if you will. When we don't have data sufficiently disaggregated, or when we don't have the data that we need to tell a story or to describe a problem, it limits our capacity to understand the full scope and scale of a concern. It limits our ability to direct funding where it needs to go to address that concern. And it also limits our ability to plan and implement services appropriately. So those are all important considerations as we think about data. And I would also like to just kind of lay on top of this as we're thinking about some of the gaps we see and as we're thinking about potential solutions, just to ensure that we're keeping in the back of our mind also, how do we build in protection for the people that we are serving in terms of informed consent and protecting confidentiality? That's also something that's going to need to be top of mind as we think of solutions. Going further with the mental health information that we had shared, more than once we heard, if we just had access to insurance information, whether that be private health insurance, Medicaid, Medicare, that would give us a much better sense of the number of people who are dealing with certain conditions. How many people are experiencing anxiety and depression? Which people? Can we disaggregate that by age? Can we disaggregate that by location or gender? That there were just some significant gaps in understanding, again, that scope and scale of the mental health landscape, particularly at local levels. So this was something that people were definitely hoping to get more information on. And again, the idea of advocating for ways to get that information in a way that gives us that surveillance and gives us that description we need to best plan and implement services, but ensure that we're protecting people's privacy at the same time. And I wanted to share just kind of a representative quote here that speaks to that. So one of our participants said, we're hearing that there's a behavioral health crisis among people and youth especially, but we don't have a good way of getting that outpatient mental health data or any outpatient data. So that's one area that I think would be really helpful for us, because if you're coming into the ED, to the emergency department, or you're being admitted to the hospital, it's much later in the game than perhaps where we want to be. Sounding the alarm if we're seeing increases in outpatient and lower level care. So being able to act proactively and preventatively would be so beneficial, is what this person is kind of alluding to here. Okay, let's talk a little bit more about disaggregation. And I want to just define that, because that's a multisyllabic word there. When we say disaggregate, it's simply going from a larger group and breaking it down into smaller groups so we can understand the unique experiences of the smaller groups within that larger group. So that could be, for example, going from the county level to all the zip codes within a county, from the overall population to racial, ethnic, or age groups within that overall population. It lets us compare and contrast the experiences of different groups and make sure that we can put an equity lens on the work that we're doing. Okay, so people gave me several examples of where they felt the disaggregation of our data just wasn't as strong as they would like it to be to help them plan and provide services. We saw this represented with the MENA community, the Middle Eastern North African community, our Latinx community, and our LGBTQ plus community. All of those were areas where people called out insufficient disaggregation. So for example, with our MENA community, we know that historically that hasn't been an option for data collection to disaggregate data. Typically that would get lumped into a white group or something like that. And the problem with that is it's going to dilute or mask our capacity to understand our MENA community in their own right, in their own experience, rather than diluting it and combining it with another community. Similar with our Latinx community, when we think of an ethnic group, the Latinx ethnic community, if that gets lumped into other racial groups and isn't given its own unique and distinct experience, again, we're losing the capacity to understand a group's unique, their own experience in their own right. With our LGBTQ plus community, people shared kind of a mixed bag of findings. We have seen progress with the US Census in that they are exploring and piloting more ways to ask around sexual orientation and gender identity, which could be a huge benefit in terms of being able to understand people's experiences along those lines and being able to disaggregate data that way. At the same time, we've seen data losses too. So in the Illinois Youth Survey, for example, asking around sexual orientation and gender identity is optional. And some school districts are just opting out of asking that question. So we're losing the ability to disaggregate and understand those experiences, which can be hugely important when we think about youth mental health and wanting to be able to disaggregate among different groups. People also shared with us language and trust barriers related to data collection. So people shared with us that, we know that in DuPage County, almost a third of our households are speaking a language other than English at home. So we know that there's a diverse array of languages being spoken in DuPage County, but much of our data collection cannot keep up with all of the, or has not historically kept up with all of those languages that we speak in DuPage County. So we're losing the ability to understand people's experience when we can't speak to them in their language. Similarly, we know that there's been a legacy of hurtful practices by some of our institutions and by our government. When I think of things like the Tuskegee syphilis study or redlining practices, we know that some communities within DuPage have reason to be mistrustful of government and institutions, that legacy still exists in people's minds. So it behooves us to demonstrate that trust over time and to demonstrate our trustworthiness to repair some of that historical damage. So we're not losing the opportunity to tell everybody's experience with data. And we can see a quote here that speaks to this at the bottom of our slide. So as one person called out for us, data on minority populations, immigrant populations is not as robust as I would like it to be. We're a government entity, so there can be trust issues. There's certainly language barriers. We do focus groups in Spanish, we do surveys in Spanish. There's dozens of languages spoken out there that we don't necessarily have a good handle on what the needs of those immigrant populations are. So I think that's a big gap. Okay. Another way that people spoke to data not being disaggregated at a level that would be most helpful to them is when we need data at a sub-county level. So zip code, census tract, things like that. And what our participant is describing here is how sometimes that lack of disaggregation impacts our ability to seek out funding. So for this particular funding opportunity, this notice of funding opportunity, NOFO, in order to be eligible to apply, the county had to be able to say, yes, we have this rate of need within our community. Now at a county as a whole, DuPage County looks very healthy, very well resourced, very wealthy, and we might not be able to demonstrate it at that whole county level. But if we can disaggregate and look at some of those smaller communities, we know not everybody enjoys those exact equal levels of health and wealth and well-being. We can identify communities where that might not be the case and then be eligible to apply for that funding and be able to have an impact within those communities. Ironically too, because DuPage is so population dense, that might be just as impactful as some of our competing people who are applying for funding as well. we could have that impact to reach a lot of people, even within a portion of DuPage County. Okay, another issue that people raised up for us was what I would call a tension that exists in the human services field between the requirement to use funder-selected metrics and funder-selected data systems. So think data systems and metrics established by the federal government, state government, that we need to report on as we are participants in that funding opportunity. Balanced against an organization's desire to maybe collect different data or data that is tailored to the needs of their organization that might be different than what a funder needs or a funder is asking for. People were well aware and acknowledged that those shared metrics are important. It's important to be able to roll up all of those smaller levels to a bigger story and tell that larger impact. But at the same time, it might not be in the best service of an individual organization. So how do we balance those needs? People also let us know because of that, sometimes they were doing multiple data inputs, multiple data entries to accommodate both what their funder needed for data and what they needed as an organization, anywhere from 2 to 6 times entering data, depending on the number of funders that they're working with and number of ways that they're using data within their own organization. So there was definitely a wish for more of a relational database option where someone could enter data once and it would populate into all of those systems. So that was the dream wish here with this point. People also shared with us challenges when there are service areas with overlapping or non-distinct borders. So for example, think about townships, congressional districts, zip codes, unincorporated areas within municipalities. People were wondering, am I double counting people? Am I missing people? Am I leaving them out when I'm counting at these levels? Because sometimes those areas overlap and I can't get a clean count of who I'm serving. So that was definitely a challenge people had endorsed. In a similar vein, people also let us know at certain levels, for example, at the municipal level, sometimes municipalities are collecting metrics or data in different ways. That makes it hard to either combine that data from different municipalities or to compare them to each other to see where our strengths and weaknesses. So for example, policing data was noted, public transportation, libraries, data on opioid overdoses, reversals, deaths. When that information is collected differently, we have 39 municipalities in DuPage County, that creates a significant amount of staff time and work to make sense of all of that. And we have some quotes here that speak to the points that we were just discussing. So this first one gets at that point about kind of the differences among municipalities. So some information we wish was easier to find, some specific overdose statistics. So if there is a way for us to identify in one location, kind of a one-stop shopping model, can I easily pull up overdose stats for Villa Park as opposed to trying to call their police department and have them give us the numbers? And then with the acknowledgement that every city does this differently, so having to contact every city and ask for that information is a big ask of staff time and effort that could potentially be used providing services and doing other things. So then this second quote here speaks to that tension that we had discussed between kind of funders at a higher level, federal, state level, and individual organizations. So our goal with our system is to connect people to services, and we do that through our service system. When you don't own a system, how do you get the data out of it? And how do you make changes to a system? We've made many changes to our database to meet that need. And when you don't own that platform, you can't do that. So kind of that sense of a lack of control or authority over their own organization's data if they don't have their own data system. Okay, people also identified some gaps when we think around tracking and coordination of data. So when we think about service metrics, if they are not connected to individuals or demographics, we lose an opportunity to understand better. So what do I mean by that? People want to know not just that our program, when we look at data at a program level, provided X amount of services, or our program conducted X number of health screenings. That's all well and good, but people wanted to move beyond just the count of what a program did and get into more nuanced understandings. So how do we understand that people are better off because of the services our programs are providing? If we can tie that information to individuals, to geographic locations, we can respond much more strategically. So, for example, if I know in the northeast corner of DuPage County, there is a strong need for my services there, maybe I use my marketing dollars there instead of the entire county. It's a more efficient use of my resources if I have limited resources. Um, maybe I know that I only need to target 0 to 5 children, so I won't spend my time reaching out to high schools. So it allows us to be more efficient and targeted with our services. And also people did note that we are seeing progress in this idea of tying data not just to what is a program doing, but being able to tie it to individuals and demographics. I'm going to use DuPage's 211 as an example. Historically, DuPage County has had a call-in line where people can request services and get referrals, and that's great. That's kind of a traditional phone line. But with the advent of 211, we know that that connects a lot more data than just the call-in information. We can get zip codes of where people are asking for services. We can get in the past week, month, year, what are the top requested services? We can look at each service category and break it down by subcategory and say, okay, within housing, who needed shelter, who needed rental assistance. So it's really amplified what we can gather and how we can understand service needs. And that's one example. I'm sure there are many more we could discuss, but just wanted to share some positive developments as well. Okay, let's also talk more about coordination of services. Just like when data isn't attached to individuals, when we kind of lose that personal or demographic information, when data is siloed, that's another way that we can lose information potentially. So if I work at organization 1 and I know that my client John Doe is diabetic, I know one piece of information. If organization 2 also knows that John Doe is food insecure, they know another piece of information. And if organization 3 knows that John Doe is on a waiting list for housing and he has a unit available, that's a third piece of information. But if none of us know all of that, we all limit our ability to help John Doe. So how can we bridge some of those data sharing gaps so we can all comprehensively understand what John Doe's needs are? Poor John Doe. This also contributes to potentially duplication of services or inefficient or inequitable services. For example, if all 3 of those organizations aren't talking to each other about John Doe and his needs, maybe there's 2 organizations trying to help John Doe with the same problem when we only need 1 organization doing that. Maybe John Doe is getting food assistance at 3 organizations, and that limits organizations' capacity to help somebody else. So being able to understand that one client's needs more comprehensively helps the whole system. So for those reasons, people were calling for, can we improve some of that cross-provider information exchange and understanding so we can best help all of our clients? And this was a discussion I had with one of our participants that really brought this point home for me as we were talking. So they said, let's just say hypothetically, we have somebody in our homeless management information system, so HMIS, and we can't locate them for some reason. We've identified a unit for them. Sometimes people have vulnerable, unstable conditions. We know they had some healthcare issues, and that's one of the reasons we wanted to get them in housing quickly. We also know that they're getting services at Central DuPage Hospital. So if the housing system and Central DuPage could talk to each other, they could say, hey, Central DuPage, can you please tell John Doe if he's in your hospital that there is a housing unit available for him? Or could Central DuPage turn around back to the housing organization and say, John Doe just updated his contact information with us, so we can share that with you and you can do your own outreach to him. Again, strengthening that system of care for John Doe. Okay. Community needs and asset assessments sort of got their own category of discussion, I would say. People shared that there are multiple organizations all required to do needs and asset assessments. So we know that our hospitals and health systems have to do them on a regular basis. So does the county for some of their grant programs, their community block and development grants. And the health department is also required to do community health need and asset assessments regularly. The concern people raised was that we are most likely asking the same or similar people the same or similar questions over and over again. And they were concerned that this would be burdensome for our community members. And when that happens, people were concerned that data fatigue, the struggle is real, and people will stop answering our questions. If and when that happens, we lose representativeness of our data. It is less accurate at telling the picture of our community if people aren't participating. So that was definitely a concern that people raised. So could there be an opportunity to pool our resources, our funding, our staff, our data collection tools to collect more and better data? Could we coordinate our efforts so that we're not all doing a little bit of the same thing, but really making that a stronger system overall to collect that assessment data? Okay. People also shared with us areas where they think we could see some capacity building opportunities. Okay. One was, can we help our staff understand the menu of available data sources that can help us do the work that we do? In Health and Human Services, we rely heavily on data to understand conditions, to make decisions, to forecast into the future. But if we don't understand all of the data sources that are available to us, it limits our ability to do that work. People also were looking for help selecting the best metrics to measure what they're doing and understand their outcomes. So help me pick the metric that best answers the question that I am looking to answer. People also wanted support building capacity around measuring implementation and outcomes. So what are we doing in terms of providing services? Did we implement our services as we planned to? Did we have to adapt for some reason? And if so, why? Did we just go rogue and not implement with fidelity as we thought we were going to? And then also looking at outcomes. Not only what did we do, but is anybody better off because of the work that we're doing? And together, using those pieces of information, we can develop a continuous cycle of how did we implement? Is anyone better off when we did that? If yes, great. If no, what do we need to do differently? We also want to help people to be critical consumers of data. We know that there are limitations to any data source. We know that there is plenty of misinformation and disinformation efforts out there, unfortunately. That has become kind of part of our current context, and we're in an election cycle year. So helping people be good consumers of data and understanding when data sources are quality and reputable, when maybe they're not, using that to our best advantage to provide and implement and plan services. People also wanted support using data for grant writing and organizational planning. For those of you who are the people applying for funding in your organizations, we know how important data is to communicate a story, to communicate a need. Having both the quantitative and qualitative data to give the breadth and depth of understanding is really important. Okay. And as we can see here, one of our participants gave us kind of that idea around data-informed decision-making and using data. Everybody says data-informed decision-making. I would say that skill and that activity in practice, data-informed decision-making, is not as easy. It's not as present as you and I would like it to be. It takes a lot of leading people to that point to say, now that we have this data, what does it tell us? What conclusions can we draw? What decisions are we going to make? You have to really hold their hand through it. So really helping people understand how to bridge that data over time and make good decisions with it. Okay, people also wanted to build capacity around understanding where our needs relative to the populations that, let me say that over, where are services related to the populations that need those services? So we can co-locate those things together. So if my population that is most in need of a service is in the southwest corner of DuPage County and my services are in the northeast corner of DuPage County, I'm creating a barrier of that person being able to get to services. There's a transportation barrier potentially there. So why not locate my services where the need is greatest? So being able to geolocate services and needs, understand the populations that most need services, and putting them there. People also recognized that they wanted to fill in the gaps of some of the quantitative findings they have. So I like to think of it as quantitative data often gives us the what. We know how much of something happened, breadth and scale of a situation. We don't always know why. So maybe emergency room visits are up, but why? What's driving that? So being able to talk to people and get more of that story, if you will, helps inform our actions so we can really tailor our implementation and our program development to what is most needed. And then last, I like to think of using data storytelling to raise up voices of people whose voices aren't always heard at the tables of decision making and the tables where power is located. So to make sure that as we're doing this work, our communities that are most impacted, that their voice is elevated into the planning process and the decision-making process as we do this work. Kind of the not about us, without us philosophy. And again, we have a quote from one of our participants talking about the bridging of that data to understanding. So there are people that are really good with data. They really understand the technical needs for data to be accurate and reliable. Yet the skill that is missing is the bridge from that to a layperson's interpretation. So how do you bring that data to the public for them to care about it? How do you influence policymakers or legislators with that kind of information? And a lot of times we just don't. So speaking to this lack of capacity to translate that, the findings and understanding for influence, to amplify our efforts. Okay. People also shared with us some promising practices and some recommendations for strengthening our data systems. One thing that was really cool to talk about with people is when they would share about how data sources and systems are becoming more robust over time for service planning and for service delivery. I gave you that 211 example earlier, but there were several people who shared how they're using their data internally to plan and to provide services, and how that's becoming more sophisticated over time. So for example, maybe there's an organization using their financial data, their programmatic data, and their client data all to troubleshoot where there are gaps and where there are concerns. So maybe the flag gets raised at the financial data, like, hey, how come we're not billing for group therapy as much as we used to? Oh, well, we changed the group therapy time or the group therapy location and not as many people can come anymore. Okay, well, we should do something about that. So using all of those systems together to best plan services for people and best identify where there are gaps. People also shared with us kind of developments with service referrals for social determinants of health. So many hospitals and health systems now are in their electronic medical records screening automatically for social determinants of health. So is my client food insecure? Do they need a healthcare provider that accepts Medicaid? Do they need housing or education services? So now I know what my client needs. I can provide 3 resources and say, here, client, I am now going to refer you to these 3 resources. And I'm going to send messages to them and set appointments. So you can go there on Tuesday at 10 o'clock. We've agreed that that's a good time. And it closes that loop of service referral. So it's not just making referrals out into the ether and hoping your client gets there, building a relationship across the different providers to provide that cohesive network of service for a client. And then also the idea of people were really interested in evolving from not just counting what we do or how much of it we do, but understanding, tying that to, are people better off because of what we're doing? So are we achieving client outcomes? And can we use that data to improve our service delivery? Do we need to do something to adapt it to our clients' needs and make our services a better fit? Okay, so what should we be doing more of? We know that the concerns that we've laid out here today are complex. They require multiple people in the room to work together. So how do we do that? One of the best starting places is convening stakeholders, getting all the smart, dedicated people in a room together to start brainstorming solutions. How can we bridge some of these gaps in data sharing? How can we build capacity? Getting people together to do that work. What can we do to foster data sharing data collaboration. One suggestion was baking that into the system, so to speak, with collaborative funding applications. So building institutionally, people working together. And then also making sure that we are continuing to build trust among our marginalized communities that might not be as have as great of trust for institutions, for government in allowing us to collect that data. We want to make sure that everybody is included in the work that we're doing. Okay. I'm just going to touch on a couple of these points because a lot of them we've addressed already. People are wanting to see more opportunities to build capacity, both at the local and regional level. One thing people shared with us was sometimes, for example, data gets distributed or disseminated unevenly. So maybe there is a state or a federal organization that is releasing county level data. Maybe DuPage and Kane County got their data, but Kendall and Will didn't. So if we don't all have the most up-to-date data, it makes regional planning hard for us. We also want to guard against the loss of quality metrics like the Illinois Youth Survey I had mentioned earlier, guard against mis and disinformation to make sure that we have accurate data out there in the community. We want to develop capacity of our smaller providers. We know that small providers, you are the person who is providing the service, making the coffee, making the copies, and handing a tissue to the person in the waiting room. It's hard to have capacity to do everything. So how can we train up? How can we provide resources that are helpful to people? Convening people in the same room. Like I mentioned, we have a bunch of very smart, very dedicated, passionate people here today. How do we best work together to find collaborative solutions? And with that, I am going to bring us to what I think is the fun part, is questions. How do we answer the questions around this? So we're curious to know the findings presented today. How does this align with your experiences in the work that you do at your organization? Are there aspects of data use, of data needs, of data gaps that we missed? Is there something we didn't capture today that you feel is important? And then we know that we are a cross-sector human services planning body. What are the implications for us as a human services planning council as we think about all of these findings? I am going to leave it there and let people discuss.
Mimi, so here's how we'll approach these three questions. We're going to break into smaller groups to give everyone a chance to weigh in on these three questions. Before we go to those smaller groups, while we're in a big group, if there are questions about the information that Mimi has shared, if it's evoked any unknowns for you, questions, concerns, are there things that you would want to clarify for the whole group before we break into smaller groups, or clarify for yourself about the findings that you've seen here? Okay, so I'm not hearing any kind of like factual or findings questions. So that's a clue that we ought to and can go ahead to move into our smaller groups. Danica, let's see, as people are departing, some folks have other commitments at 3. I want to let you know that in the chat, there is an evaluation survey. So if you need to take off before we do the smaller group work, please click on that survey link to help us understand the value of the presentation for you. In the meantime, Danica, I'm going to ask you to set us up for 4 breakout rooms. And we're going to have 4 facilitators. That's going to be Beth and Ava and Rosa, Acela, and Summer. And as we prepare to go into those groups, I would like to share something with all of you to prepare us. When we have planning discussions like the one we're about to have, inevitably, we find ourselves in the uncomfortable area of disparities and differences in the way that members of our community have had their well-being attended to. And in order to have these difficult discussions, members of our Health Equity and Access Response Team have spent about 5 hours over the last 13 months working through a guide for working together to make sure that we can create a space where the difficult discussions can happen without bringing further harm and in a way that can lead us toward stronger relationships and to good solutions. And here you see the group that got together last April. There is another group that met before this one. There are about half of the members are in overlap. That group developed agreements for working together in these 5 areas. And what I want to do is encourage you, as Danica is putting together our groups with our facilitators for breakout, lock your eyes on one of these open categories: eyes, ears, hands, minds, or hearts, and take a look at the agreements in that area. Let's borrow these from the Heart Coalition for our work today. And I encourage you to take these in and bring this kind of approach and sensibility into our work as we have this smaller group discussion.
We're all set, Dave.
All right, here we go. You'll have a facilitator. The facilitator will make sure that this session is recorded and/or notes are taken, so nothing will be lost. When we come back together, there won't be time for a full report out from everyone, but I promise you that nothing is lost in the information and the discussion that we're about to have. All right, Danica, we're ready.